All right, welcome to how to stop sabotaging, how to stop tongue thrusts from sabotaging your caseload. I am Callie Stone, and I am the founder of the STTP Training Center. And I'm excited to have you here today. I set this up a little bit differently, and I'm changing technology. So we may have people jumping in as we proceed here, and my goal is to have it as a meeting rather than a webinar, because the webinars are kind of restrictive. It's hard for me to interact with you as much. Excuse me. So we will we'll see how it goes. Okay, but my purpose of being here today is to really help you identify that whether you recognize it or not, tongue thrust is likely sabotaging your caseload. And I'm going to go ahead and share my screen here for the presentation. I'm going to whip through this really fast because I want to get a lot of information out to you. Hello. Let's start at the very beginning, okay? All right, let's start here. All right, hopefully you can see my screen. You should be able to. So as I mentioned, how to stop tongue thrust sabotage in your caseload, regardless of the age or setting. We used to have the wait till 8 and only in the clinic kind of mantra, and that is not the case at all today, and we'll tell you why. Okay, so and I hope I don't miss somebody who's trying to come in, because when I'm on this screen of presentation, I'm not able to see that as well. So hopefully we're not missing anybody out there. All right, so these are the outcomes that I want you to be able to take away. Today, you're going to be able to recognize the misinformation that continues to persist in the general public and professionals related to tongue thrust. You know, because this is my world, I think, oh, we're making progress and people are understanding it. And then I realize there's still so much misinformation out there, so many just flat out wrong. It's just incorrect. So today we're going to recognize those, and by giving you new information and explanation behind it, rather than just throwing something up there on the internet, you'll be able to recognize the misinformation and be able to hopefully perpetuate the better information, the more accurate. Okay. I also want you to be able to identify the effects of tongue thrust at any age. They look different at different ages, and so we're gonna talk about that a lot today. And identifying the tongue thrust that's on your caseload. So it's not always obvious, and I would argue that you have tongue thrust on your caseload. You may not be treating it because you don't recognize it. Okay, so we're gonna give you a little bit. I call it putting on some new goggles, so you can recognize it, identify it on your caseload at any age and in any setting. And then finally, which STT program or protocol is appropriate in which setting. Like I said, we used to have the wait till 8 in clinical perspective, and in the recent years, we have expanded that because of clinical need. And I also realized that there were things that we could do. We may not eliminate the tongue thrust until they're over age 8, but there are many things we can do to mitigate it and minimize the effects of it. That is within our scope of practice, that is within the settings we work in, and that is value added, that it's very important for what we do in our setting at whatever type of professional we are. Okay. And then finally, we're going to determine when to intervene and when to collaborate. So, you know, as with anything, well, and let's just talk about that. Okay. So first, I need to start with my background and perspective. This is my disclaimer, because this is my perspective. So this is the angle I come at it from. And I think if you recognize this and understand this, then what comes to follow will make more sense. Okay. So I started out in a, very much identify as a medical SLP, a clinical SLP. And that is because I was really focused on brain injury. I love neuro rehab, and that's where I was working. I was about 3 years out of school and had a referral on my caseload who was a 14-year-old tongue thrust. And I didn't know what to do with a 14-year-old tongue thrust because he didn't have any delays or disorders. He had no articulation errors at all. In fact, his teeth looked great because he was in orthodontia. But his dad was a doctor. And so as a result, they were in, we were the PPO provider for the doctor's group. And so he came in with a diagnosis of tongue thrust and the expectation that I, as a speech language pathologist, was going to treat it. And so I did what we do, right? I got into the research and realized that it was abysmal. I reached out to my colleagues and my mentors and said, hey, what do I do with tongue thrust? And what I heard from all of the above was standard practice at the time was this year program. And then they would come back for tune-ups as needed. Well, very quickly, I recognized that that was not going to work in this setting because I was fighting for 8 sessions with my brain injury patients, right? So who's going to give me, the year of therapy and pay for it? They're not. And then even if they did by some miracle, no 14-year-old kid without any kind of disorders or delays is going to stick with a program that's intensive for a year. Just not going to happen. So, I did what we knew, and then I just used my clinical judgment. And my background was actually in my patients, and the things that I was treating was apraxia and dysphagia. And so what I quickly realized was that this tongue thrust is an oral phase dysphagia, and I treated it as such and suddenly had really amazing outcomes. And they were not what was happening, in that standard practice, that best practice at the time. And so what happens when you have good outcomes, more come to you. And so I suddenly had this little trickle of tongue thrust referrals from orthodontists that knew that that's what I did and that I had better outcomes. And so it just kind of organically grew from there and refined. When I started a private practice, I had that kind of niche of orthodontists who were sending me those patients, and they were private pay clients at that point. So it's very, very important that the efficiency is there, right? I want to make sure that they're getting the value for every single time they write that check. But because they're writing the check, they're very vested in getting through it very quickly, right? And so there were just some things that accelerated the outcomes and made them pretty unusual. The other thing that I did, and that you may notice, is that I always call it tongue thrust. I don't call it oral myofacial disorder. And again, that comes from that background. No 14-year-old wants to be told they have an oral myofacial disorder, right? I mean, it's just like, it's horrifying. Not because it's horrifying, but because it sounds really scary. And so I don't want it to sound scary. I want it to be very layman friendly, right? I want it to be very public friendly. And so that's why I use the term tongue thrust throughout everything that we do at the STTP. It's not because I don't recognize OMD. It's not because I don't agree with OMD. None of that is true. Absolutely, OMD are probably the most trained and definitely have the most research for tongue thrust. But we'll talk about that in a minute, why that's not, that's a part of it. And so I'm not discounting it at all by using the term tongue thrust. I just want you to understand that it's because I want it to be more public friendly. So I use the term tongue thrust. So we refined it and tracked it and standardized it in 2004. Later, after many years of outcomes and moving forward with this, I had a health crisis and I sold my practice and went into a university setting. And with a university setting, what I learned was, you use the skills you use as a clinician, right? You have your toolbox and that's what you use. And we're constantly doing continuing education. We're constantly learning from our colleagues. We're constantly building that, right? So as a university clinical professor and supervisor, I was teaching and training and realized that the students were very concrete, first of all, and because they didn't really have clinical judgment yet. And they just took it very differently. So it was not the same training as my clinicians who worked with me, who trained at my side and refined and developed it with me, and who could make very quality clinical judgment. And so that's when I realized that we needed to certify. It was important to have standardized training and not just an off-the-shelf program that you just pick up, read the text, and apply it, because the STTP is very different from any training that you've had, because it does take from these different perspectives. So as a depending on what setting you're in and which population you work with, you may or may not have this skill. It's very, what I found is I didn't realize it at the time, how unique it is to me and for these reasons. So, so the university clinic is why, or my experience in the university clinic is why we then took the protocol and standardized it. Okay, that's when we decided that it needed not just the protocol and the way that it's administered, but the way that we train it needs to be systematic and making sure that you really know what you're looking at. And that's why I'm here today, is because I still feel very, I feel it's very important to understand the underpinnings of tongue thrust so that you can recognize it, because it's just not, it's under-recognized, folks. It's everywhere and you're not seeing it. Okay, I know you're not. So then I went back into healthcare. Once I got my health all straightened out, I went back into healthcare and was in the home health settings with all ages. And again, I saw trends that were happening. And with these kiddos, I was back in pediatrics and noticed that these are now my kids who do have delays and disorders. Okay, remember that before, tongue thrust may or may not have any articulation effects, and almost always, and what the STTP was originally designed for, they don't have any developmental delays or disorders. So in my home health, all my kids did, right? And many of them were feeding. And so I took, again, a lot of that information that I was gleaning and things I'm hearing, questions I'm getting at the STTP about tongue thrust and trends. And we developed, I developed the early intervention program. And that is really, that's where that came from. It was because I was in the real world with kids that were needing help progressing through those early intervention years. And then finally in the schools, as I'm working in the schools, and I, again, was applying what I do across my caseload, and the conversation was, how are you getting these outcomes? And I had other colleagues coming to me saying, wow, what are you doing? Because I worked with these kids for 3 years and I didn't, and they were still on my caseload, and you've been with them for 3 months and they're exiting. And so I looked at it, I was like, oh, wow, you're right. I implement because I recognize the impact of the lingual muscles. That's what we articulate with, folks. We articulate with our tongue. So if your tongue is not balanced, if it's not working all the muscles in synchrony, right? You guys are SLPs, you know, it's not one muscle, right? It's a complex core of muscles that work together, just like our legs and just like our arms. And so if we have weakness, it's so dynamic and it shows up in really insidious ways. So that's my perspective, that's my background, and that's where this all comes from. So keep that in mind as we progress forward, okay? All right, and I know I'm talking fast because I got lots to cover, and I want to keep this, I want to try and keep it to an hour. We'll see if I'm able to do that. All right. Excuse me. So why are there so many misperceptions out there? Well, because we have these different buckets, right? And we, as much as we try, we still end up with, we kind of come out of one of these buckets, or we treat in one of these buckets. So within oral myofascial disorders, by far is the place where tongue thrust is most recognized and most researched, as I mentioned earlier. But within that bucket, tongue thrust is a little teeny tiny niche, right? You've got cleft palate, you've got facial congenital deformities, you've got syndromes. There's all sorts of things that fall into OMD. And tongue thrust, again, is kind of unique because there isn't generally any kind of disorder or diagnosis with it that is more, you know, congenital, chromosomal, more obvious, right? It's more insidious. Everybody, not everybody. Tongue thrust is very common. OMD as a bucket is more specialized. Does that make sense? I hope I described that in a way that made sense. Articulation is probably where most SLPs think of tongue thrust. They think of it as an articulation effect, right? They think of it as the fronted R's, I mean the fronted S's, the lateral or the fronted S, right? That slushy, airy sound that comes when that tongue is forward during speech. So that's how we recognize. But like I said, my 14-year-old, my very first tongue thrust that ever came to me had no articulation errors at all. It was beautiful. And if I would have told him he had an oral myofascial disorder, he would have probably passed out. His parents would have probably passed out because it's just not something a 14-year-old wants to hear. It sounds very technical and scary. So then there's the dysphagia bucket, which is ultimately the bucket that I came out of because I recognized that it was a reverse swallow. Instead of an anchor, a squeeze, posterior swallow, that is a normal swallow, okay, what we call a posterior swallow. And they used to have all sorts of terms there too, like a disordered swallow or an infantile swallow. Again, 14-year-olds don't want to be told they swallow like a baby. And so I recognized they reversed it. They, instead of going posteriorly, they reversed it. So I now call it a reverse swallow. And that reverse swallow is the thrust swallow. So it's they're pushing forward and flipping the bolus back. Okay. So the dysphagia, again, very much that's actually the diagnosis is an oral phase dysphagia. But most SLPs who work with oropharyngeal dysphagia are worried about aspiration and safety. And again, these tongue thrusters, they're safe. They're just compensating. And the reason that they're safe partially is because it's oral phase dysphagia. And generally, because they're young, so they're compensating. It's not until later when it becomes, when they become older and the muscles are less able to compensate, that we get into a development of oropharyngeal dysphagia and recognize that that tongue thrust is actually a contributing factor to their oropharyngeal dysphagia, and they may or may not be safe eating. So that's been my experience on the geriatric side of things with, if it doesn't get remediated and eliminated when they're young, you can have, you know, TMJ issues. You can have oropharyngeal dysphagia, aspiration pneumonia, choking. It can become very, very serious and often does. So the STTP falls right here where these all three come together, because I do recognize the value. It is absolutely in the scope of OMD. Some individuals will have articulation effects, and all will also come from that dysphagia. We're eliminating an oral phase dysphagia. But very few people are trained with this kind of perspective. And those are the goggles I'm going to give you today. Because of that, that's just within our profession, but there's also the controversy across disciplines. Historically, these are the three professionals that deal with the three scopes that intersect with tongue thrust, right? Dental and orthodontic, those are often where our customer or where our referrals come from. And that is because they see it with the dentition. And orthodontics, some orthodontists, I've been told that they love to move structures around, but they hate that tongue interfering. So if they are, if they've been educated and are open-minded, they recognize the impact of the tongue on their orthodontia. So that's oftentimes where we see, and they historically will address it with appliances, and the outcomes on that depend. The outcomes I see are poor, because that's why they didn't work with the appliances. And so therefore they're coming to me as a speech language pathologist to eliminate it. So they've tried baskets and spikes, and they've had braces, and they've been through the whole process. They've told them where to put their tongue, and then it just compensates. It moves around it. And they end up on their second or third set of braces, and then they're back. And by then the orthodontist is like, just get rid of the tongue thrust. I don't care, whatever. I'm not able to tame the tongue. So that's typically where that comes from. But the orthodontists do treat tongue thrusts, and because it affects their orthodontic programs and their dentition, it does fall in their scope. Of course, we just talked about how it affects our scope of practice. And then the oral myologists, again, they are the specialists with those oral myofacial disorders. And so it does historically fall in that realm as well. And oral myologists, you may or may not know this, are not just speech therapists. They also, sometimes I've seen occupational therapy, but very, very common. I've actually trained some oral myologists and some dental professionals with the STTP, and we all three kind of crossover when it comes to tongue thrust. Okay. But we have very different perspectives. Actually, there's a course for that in the training center as well, because it is very, it's fascinating. So what does the research say? It's still abysmal, but there is increasing evidence in the literature that it does actually exist. There are fewer and fewer people saying that it doesn't exist. Those tend to be old school. People recognize it, but they still don't know what to do with it. And part of that is because the causes are not definitive. And so because it is kind of being stuck in that developmental phase, and because there isn't necessarily a disorder, it's hard to delineate that. And when it's hard to delineate that, it's hard to have evidence, right? Interestingly, there is a little bit of research that is coming out about oral phase dysphagia leading to oropharyngeal. And as I just mentioned, I saw that for years in my clinical practice, because I was primarily treating the geriatric population and the adult population in my medical practices. And, we would do a video and you would see this huge tongue thrust, the reverse swallow, and they couldn't compensate anymore. And so they couldn't protect their airway, and they were aspirating on everything. Ironically, they respond very, very well to the STTP2 as well. Although I'm not eliminating tongue thrust at that point, just like in the schools where, we're dealing with the articulation in geriatric populations. I'm just trying to get them safe swallow. I'm not going to eliminate the tongue thrust. I just want their tongue to be stronger. Okay. All right. So while all of this deliberating exists still, we have patients and students and littles who need intervention, right? So it's sabotaging your outcomes. That's why you're not recognizing it as a contributing factor to those residual R's. You're not recognizing, and if you are recognizing, you don't know what to do about it. It's like, okay, manner, place, and voicing is not working. I've had this kid on my caseload for 3 years and we're stuck. Okay. So we have to start with the definition. The first place we have to all be on the same page is the definition of tongue thrust. Sorry, excuse me. Again, I think we're making progress, and then I get online and even Wikipedia. No, wrong. It is not. It is a tongue thrust is a forward, depressed placement of the tongue. Okay. Forward and depressed at rest, which may or may not protrude through open lips, but often protrudes through open teeth. And this is, people always think that it's like pushing through those teeth on the top. And that is not actually what's happening if you actually look at inside of their mouth. Okay. So it is a forward depressed placement of the tongue at rest, which may or may not protrude through open lips, but often protrudes through open teeth. There's a couple of key words in there that we're going to get to that you're going to understand. Oh, okay, this is why I can address it on my caseload, right? It's at rest. And the tongue thrust is exhibited during a reverse swallow. So the tongue thrust is actually a resting posture, but it's exhibited during the reverse swallow. Okay, that is for everyone. Now, there may be other things, and that's where we get into the articulation, right? But the articulation effects are not for everyone. This definition is the diagnostic. If they meet this diagnostic criteria, then they have tongue thrust that is appropriate to intervene. Okay. So not all tongue thrust is created equal. We've talked a little bit about this, right? This is, I think, these pictures are what clinicians generally associate with the tongue thrust, but it may not be. It may be a little who always has something like a pacifier or a thumb in their mouth. Okay, and so when that's out of the mouth, you see this open mouth tongue, right? Maybe we're talking about a teenager who has had, or maybe we're talking about a 9-year-old who has braces on your caseload at school, right? 9-year-old in braces, probably going to be a tongue thruster, right? You're going to see this jumbled dentition, and we're going to talk about why, because during this process of development, the tongue has, so, okay, let me back up just a little bit. Yeah, let's go here. So my point with this slide is just to recognize that depending on the age, their teeth may or may not indicate what's going on. Okay, this is the most common, but also if they've already been through orthodontia, they may have beautiful, beautiful palate, beautiful teeth. And here's why. So when a little, if you think about a baby, right, they've got kind of got a baseball head, right? And that tongue is forward and depressed because they're suckling, right? And so as they suckle, it pushes forward and it flips the milk back, right? That's what suckling is. And so that is very, very normal. Yeah, I'm just going to leave it there. I'm not going to go into all the other details of that because that's in the course. Okay, it's in the early intervention course. But to understand, this is what I want you to be able to understand so that you can teach it to caregivers and to parents, is that in that development, so we take that baseball head and we take that suckle swallow, and as they start to grow and develop, they start to elongate. And with that elongation, that tongue starts to elevate on that palate. It stretches as the face stretches, okay? So what happens if you have something sitting on the tongue, like a thumb, like a pacifier, like a bottle, anything that is keeping that tongue in a depressed posture, it's not allowing it to elevate and those muscles to develop, okay? So they're still in this forward, kind of like an advanced suckling, right? So we're gonna call that, historically it's called an infantile swallow, but I'm gonna call it a reverse swallow, okay? So they're stuck in this reverse swallow. Well, what are the effects of that? When you see, if that tongue is down, it hasn't elevated and spread, because as that elevates, that tongue sits up there in that palate and it spreads that dental arch. As it spreads that dental arch, it allows room for the teeth to descend, right? So if the tongue is down, that arch is going to be high and narrow. It hasn't allowed room for those teeth to descend. And so you're going to have jumbled dentition. You're going to have crowded dentition. You're going to have, what is, everybody is thrusting to answer these questions here. Everybody is thrusting until about that transition from breast and bottle to table. So whether that is, you know, a cup, a spoon, a plate, whatever. And that's actually, we're not transitioning very well with that anymore. And so that's why we're now we're getting stuck more, because we're not developing that oral progression of elevation and spreading of the palate for that descension of the teeth. And so then we don't have great contact and our teeth are all jumbled up. And so then we start to chew all funny because we don't have closure, or with the contact, or we have weak muscles. And so we're not rotating the foods around. Okay. And so that's what happens. That's what takes that normal infantile tongue thrust and gets them kind of stuck. And the older they get, the more tongue thrust is defined, because they're getting farther and farther away from that developmental norm. But that transition by 12 to 18 months, they should have a posterior swallow. They should not be demonstrating a reverse swallow at all after they are on solid foods, okay? So here are some potential contributing factors. Again, this is what makes it difficult, again, to identify cause and effect, because there's all of these contributing factors that lead to that kind of getting stuck, if you will. So congenital, you know, I joke that you can tell I'm British because of my teeth. Some of that is just it's handed down generationally. And so we see those smaller oral cavities, right? Infant feeding problems, like I mentioned, if they're not progressing through the feeding hierarchy into more and more advanced feeding, then you're likely to see kind of being stuck in that infantile swallow. Enlarged tonsils or adenoids. Again, if you've got, we are designed as that face elongates and that palate spreads, it also, our sinuses open up, right? So we have, we start to breathe through our nose because it's filtered and humidified. We are created to breathe through our nose. But if something is kind of awry in the sinus department, then we have this bigger tube, our throat, that we can still pass air through. Well, again, if the tonsils and adenoids are enlarged, that's going to be impacting both the sinuses and the oral mouth breathing, but mouth is bigger. So we're going to be breathing through our mouth more. If we're breathing through our mouth, where's our tongue? It's on the floor, because if our tongue is up, then we're breathing through our nose. Okay, so We'll see enlarged tonsils or adenoids, allergies, chronic sinus infections, keeping that tongue down so that they can keep that airway open for good exchange. And then, like I mentioned earlier, the oral habits, digit sucking, prolonged pacifier, bottle use, pencil or pen chewing, blanket chewing, anything that keeps that tongue down rather than elevated is going to be a potential contributing factor. Additionally, what you'll see as a common characteristics, you're going to see that depressed resting posture, like we just talked about, and why. The open mouth breathing, right? We just talked about and why. The reverse swallow, we're not going to go into that today because that is definitely the more advanced. That's one of the things that we really train in the STTP 2 certification course is that reverse swallow and how to recognize it. Because again, historically, the way that they diagnose tongue thrust is terrible. Because if you, we'll get into that in the course, but if you're interfering with the swallow, you're not going to get a good outcome, right? So the bullfrog effect is a way that I've learned that I was assessing the swallow without being invasive. And the really nice thing about that is it works online too. So now that we do a lot of our things online, it's just understanding that a reverse swallow is a common characteristic, but we're not going to get into today the nuances of that because it is much more advanced than this introductory presentation. You may also see that they are avoiding chewy or tough foods. Now, this is something you can definitely see in the schools, right? Excuse me. If, again, it's just a common characteristic. If you have a student that you notice is, chewing on the side or avoiding, they just like soft foods, lots of, soft and easy, like tends to be the processed stuff, then that might just kind of go, should I look a little farther? They've got some articulation issues and they're avoiding these foods. And I see that they're breathing through their mouth. Maybe I should look a little, maybe this is a contributing factor, okay? Abnormal gag reflex, hyperactive or diminished. Again, probably not something that you're going to look at as much unless you are actually eliminating the tongue thrust, because it is a little bit more invasive. Choking, like I mentioned, I wouldn't think of choking in the schools, and I wouldn't treat kids under the age of 8 for tongue thrust elimination. But I did have, when I had the talk shop, I had a call from a parent who was pretty distressed because their 6-year-old had choked on spaghetti at school, and it had actually resulted in an ambulance ride and a video fluoroscopy swallow study at the local hospital. And lo and behold, he has tongue thrust. So I've heard that you do tongue thrust. Can you help me? And of course, my pat answer was always wait till 8. But this kid had just had a choking episode at school so bad that he had to go to the hospital. And so I recognized at that point, and we had a conversation about, he's probably won't progress through quite as quickly. He's not going to have the focus and the intrinsic motivation, but he did have a pretty severe common characteristic, and he did come in with a diagnosis. So you may see this in the school and you may recognize it. Again, we're not going to treat the swallow in the school because it doesn't have an academic impact, right? But nonetheless, it was a school setting that actually demonstrated that need for me. And again, helped me think outside my restricted box that the protocol was developed in. You'll also see that a lot of times these kids will use liquids to wash their bolus. So meaning that, they're always drinking to wash down whatever it is they're eating because they just don't have very good clearance. All right. They also will tend to be messy eaters. You may have oral residue, messy faces, crumbs around the table. Again, like I mentioned earlier, the orthodontia, the malocclusion, I think that's the most common place that people think about tongue thrust. And it's just because, again, the orthodontists tend to address it with their palate spreaders and their baskets and their spikes. And so people are just familiar with that. It's definitely a common characteristic. That high vaulted palate, we talked about that earlier, and what that looks like, that high vaulted palate, because the tongue did not spread it out. And then right behind that, right behind the front dental arch here, are the rugae, they're the bumps. And I'm here in Boise, Idaho, and so we have what we call the foothills, and they're like these little foothills that you can just go and hike, and they're not, I mean, they're good size, but they're kind of rolling hills, right? That's kind of what our rugae is. When somebody uses a posterior swallow, because they're pushing against it, they're resting against it, so it kind of wears it down. A tongue thruster, because they're down on the bottom of their mouth, and this is even if they've had orthodontia and they've had this beautiful palate that's nice and wide and these teeth are beautiful, if they have those sharply defined rugae, what I call the sawtooths, they're jagged and they're not sharp, but they're jagged. You see them in there, and they're very defined, and that is because they haven't had anything wearing them down. The tongue has been on the floor of the mouth. It hasn't been pushing. And even when they had the palate spreader, tongue was still down, right? So those sharply defined rugae are a common characteristic even post-orthodontia. And finally, the ones that it took me years and years of using them, the protocol, to realize, wow, that tongue, the base of tongue is the same muscles, and the lateral edges of the tongue are the same muscles that are necessary in these really difficult articulation challenges that we get on our caseload. And so you cannot expect that a student is going to be able to achieve a generalized bunched R with poor musculature. Okay, so if they have either hypotonicity, right? You have to address the muscles. You have to, because they are a common characteristic for this population. So if you are stuck with a frontal or lateral lisp, a residual R, fronting, generalization, any of those kinds of articulation errors, consider the tongue thrust. Look at the lingual strength, coordination, balance, use, and that's everything that's in the STTP-M. It's how to assess that and how to get unstuck, okay? There are generally weak base of tongue and maybe even lateral, but you're going to see that most of these tongue thrusters can do all sorts of crazy tricks with the front of their tongue. Sorry, I've been talking too long. Starting to get that rasp. So they're very talented with the front of their tongue because it's compensating. It's compensating and doing all the work of the posterior muscles. And so those are some of the common characteristics that you see. So when is it appropriate to intervene, right? Just like with anything else in our scope of practice, it depends. Oral habits and contributing factors can be addressed at any age, right? Articulation can be addressed developmentally as appropriate. Like I was just talking about, you can address it with the traditional manner, place, and voicing. But if something isn't progressing the way you would expect, then take a peek. What is their tone and muscle function? What's the tongue actually doing? Not just where is it at, but what is it doing? What is the muscle? How are the muscles activating, and where are they breaking down? Okay. And then dysphagia therapy. The tongue thrust elimination should be addressed when a child is old enough to understand and change the behavior with education and support. Typically, we say age 8 because that's usually when they're able to sit down, they have enough internal awareness. The STTP2 is a very intensive program, and so you need them to be able to attend and take perspective of what's happening. They need to be able to communicate to you what's going on inside their mouth, and you teach and you go back and forth. So 8 is commonly accepted. I have treated them younger for the reasons that I just mentioned earlier. I have had quite a few now, but I still think the best outcomes, they get there, but it takes longer, more frustration on parents and kiddo and you. So at age 8, they tend to just whip through it without any difficulty. And very predictably. That's what's crazy. For me as a clinician, and especially working with neuro and brain injury, so much of what we do, and if you think in the schools, the I guess equivalent to that would be language, right? It's just so nebulous and so cognition and language, you know, there's always more to do. But with tongue thrust, it is so concrete and so predictable. And once you learn what you're looking at, it's just plug and play. And if you have the training to understand what to plug and when to play, it's so predictable. And when I looked at the data, I was like, oh my gosh, we have some kids 3 to 5 sessions that they can eliminate it because they have such awareness and intrinsic motivation, and they can just, you know, they just need a little whoop, and they're there, a little tweak. And then you've got others who, you know, 10, it's so rare to have anybody past 10 sessions. They just get it. And that sweet spot tends to be 5 to 7. I usually in my outcomes, I'll say 7 to 10 because I want to be on the safer side. But you know, 7 is really the magic number. 7 is really where probably 80% or more of those kids that we actually eliminate tongue thrust fall, regardless of age. It doesn't matter if they're 8 or 18. If they're 14 or 44, they still boom, boom, boom. It's so tangible. And most of what we do in speech therapy is not that tangible. So I find it very rewarding and fun because I can look at them, I can educate them, and I can predict exactly kind of what is going to happen as we progress through, right? And if we hit a hang up, we have issues for that, or we have solutions for that too, because everybody hits a hang up at some point, right? We all do. And everybody does. It's just where and how we address it. Okay. So how are we gonna stop the sabotage on our caseload? Well, first we have to recognize it. We have to recognize the contributing factors and the common characteristics. And then once we recognize them, then we identify and intervene. So how do we identify it? We identify it by understanding those developmental norms, oral development, and where they are stuck in the progression. Okay, why? You know, if they're little, then how do we facilitate through that? If they're older and their swallow is hardwired at this point, right? Very, very automatic. We're not going to see them. So if we have a chance to get our eyes on them and be in their environment when they're little, we can keep them from getting stuck and supporting that oral development, supporting that elevation of the tongue, making sure that the airway is clear, making sure that there's nothing impinging that tongue and keeping it down, making sure that they're getting lots of good progression through the feeding process so that they can learn to use their mastication muscles and their posterior swallow develops. It's just so automatic. Our bodies are designed to function properly if we give them an environment to do so. Okay. The articulation errors in speech intelligibility. Okay, maybe that's what you're identifying, and so you're going, okay, you're going to do a regular articuval, and or maybe you've had this kiddo on your caseload already, or maybe you're coming into a new school year and you get a student on your caseload, and you're hearing particular error sounds. Maybe you're hearing that flat R Okay. And they're 9. You know, the only articulation error is the R. Okay. Their speech intelligibility at the conversation level is poor, right? They're not generalizing. You're hearing maybe other articulation sound errors kind of pop in at the conversational level. I would encourage you to dig a little deeper, because that tongue is not hitting its targets. It's not being, so is it hypertonic as a tongue in general, that you need to do some oral exercises to get all of the tone, the facial tone, you can even look at them sometimes and you'll see that. Again, that's the exception, not the rule. The rule tends to be very, very, very tricky, okay, unless you know what you're looking for. So you're listening and you're watching for these characteristics. Are they using the front of their mouth rather than the back of their mouth in their articulation, okay? And that's going to require a little bit of training and listening and clinical judgment development to really know which of these kids on your caseload you need to dig a little deeper with. But you're going to be able to identify them and go, I think there might be a thrust going on here, okay, that's contributing. And then dental malocclusions or orthodontia. Like I said earlier, if you've got a 9-year-old on your caseload with braces, what's that telling you? If you have any student that is, you know, that has the jumbled dentition or they're post-orthodontia, all of those are telling you they likely have a high narrow palate. The reason they likely have a high narrow palate is because that tongue is resting on the floor of the mouth rather than the roof of the mouth, okay? So then once we've considered what the contributing factors are, what is it that I'm looking at and addressing, then I'm going to look at how old are they, right? And based on their age, I'm likely to see them in different settings. So birth to 5, they're going to be at home. They're going to be in preschools and daycares. Okay, this is where you're going to see this population. Depending on where you work as an SLP, you may or may not see these kids on your caseload. Okay, these are kids you may see on your caseload in your world. They may be your kids, they may be your friends' kids, they may be your family members, nieces, nephews, they may be your grandkids, right? So education as to how we can facilitate healthy oral development, we've got you. Then if these kids are coming to you, they're on your caseload, they're in that 5 to 8 year range, they're probably in an elementary school, they may be homeschool. Again, home is still an area where we're identifying these kids and where we may be treating these kids. And these are also the ones who you may be seeing in the clinic because of articulation errors or because of other disorders and delays, okay? But these are, they may start emerging into your clinic at this point. But that's usually where they're identified, as either at school or by their pediatrician coming into a clinic because of articulation errors, okay? I would say most of the 5 to 8 year olds, it's articulation. And then the 8 and beyond, these are the kids that you're going to see, again, in elementary school, in the community. So you may see these kids, they might be out in activities, sports, you know, church, just other places where they're coming in contact with you. And again, you're hearing specific articulation disorders, or you see that tongue in that kind of setting. Secondary school, so we're talking about the middle and high school grades. Definitely, you're going to see these kids with the orthodontia and or the articulation effects. And then in the clinic, they may just be coming to you because you have a referral from an orthodontist or an ENT or a parent asking for some help. So, all right, real quickly, early intervention program. The early intervention program So we have lots of courses in the STTP Training Center, and some of them go into the different avenues, the different kind of corners of tongue thrust, if you will. But what I wanted to really bring to you today are these 3 different programs and protocols and trainings that are available depending on where you're at. Because again, I think we have this perception of wait till 8 and in the clinic only. So to recognize that you can access the early intervention program and use it for caregiver training. It's implemented as early as transitions from breast to bottle and plate. So really probably around 6 to 9 months is where you start to educate the parents as to what that oral development looks like. That when they first start feeding, right, they always push that bolus out. They're on purees and they're pushing it out. And as they start to get used to a spoon, it'll pull it back. Well, we have some things that are happening in our world, and I go way into it with the STTP train or the EIP training about how to set up the environment to facilitate a successful transition from breast and bottle to plate and not get stuck in that that thrusting swallow. Okay. And this program, it goes beyond just that transition. So if these kids are coming into you at 12 months, what do you do? 36 months, what do you do? So it's broken down into developmental ages, and at each one of those, it has the norms and ways to what the child is going through, what developmental stage they're in, and how you can set up the environment and their feeding to be able to facilitate optimal oral development, be able to get that tongue up, be able to get that palate widened out, be able to get those teeth coming in straight. And I'll tell you, it's pretty amazing. Yeah, I'll leave that for the early intervention program, but I have some pretty cool stories about how we've been able to actually turn that tide and potentially change familial patterns of braces and retainers and, you know, just lifelong TMJ, all those kinds of things. So pretty cool stuff. Early intervention works. We know that as clinicians, we know that as a practice. So why not in tongue thrust? Why not? It's absolutely amazing. For our school SLPs, the STTP modified, right? The STTP modified is a protocol for the identification and treatment of articulation errors resulting from tongue thrust. So I'm in the schools, and I'm actually in the schools online, so I really have limited parent involvement. But I know that these are some of the issues that I deal with in the school, and I know you do as well. Short session times, heavy caseloads with group sessions. And the biggest thing is they have to qualify for services, right? And so it has to have an academic impact and meet the IEP rules. And tongue thrust doesn't. And so the speech intelligibility and articulation, that is a recognized area for an IEP. And so we can treat that. We absolutely should treat that. And we are going to look at what are the underlying causes of that articulation error. And we're going to do exercises. We're going to determine which muscle of the tongue do we need to facilitate, and we're doing it all for that resting posture and that articulation, so that we can get better efficiency movement of that tongue from the anterior and to posterior, from the neutral vowels, and being able to move that around effortlessly. These are kids who have, like I said, lateral S, residual R, fronting processes, fronted S, what they call the lisp, right? The fronted S, the co-articulation effects. Like I was just talking about, they just co-articulation and generalization are very, very difficult for kids who have tongue thrust involvement, okay? And finally, whether you are in the clinic or maybe, like I said earlier, in the clinic and you contract with schools, so you're in both settings, the protocol for the assessment and treatment of tongue thrust, the STTP2, was revised in 2018 to address some of the changes that I had seen in my caseload. I noticed that it was taking some different exercises before I might just, I mean, in the first 10 years, nobody needed anything for masseter activation and rotational chew. They had that. In the last 10 years, it's very, very common that they get stuck there. And so that's just one example of where we updated and added some exercises. Also refining the bullfrog and recognizing the posterior swallow for that training. So it is the program that eliminates tongue thrust by retraining the resting posture and the active posture during swallowing and speaking. It does not address articulation, however. It's just eliminating the tongue thrust. So it is an intensive program for 8 or over, and it typically takes, like I said earlier, 7 to 10 visits. 7 is really the magic number for most of them. Some are down in the 3 to 5, and some I've had at 10. But it's typically over a 2 to 3 month time period, and it's very, very efficient and very, very effective. So for today, for this promotion, I guess we can call it, I'm doing some bundles because I feel like, again, we cross over a little bit. So the early intervention program is that birth to 5, really, or not birth, but let's call it 9 months, 12 months to 8. Okay, what am I going to do before they're clinically ready or clinically demonstrating, right? This is the behavior, or the behavior modification and environmental modification and caregiver education. That's really what that is. Lots and lots of let's stop it before it starts. If you're getting these kids a little bit older and you're in the schools, I'm throwing the early intervention training in with the STTP modified, and this is really the articulation program. Okay, so we have the caregiver education, the early intervention. Then we have, if they have articulation effects, which not all tongue thrusters do, but if that's what you're treating, the STTP modify addresses that. And I have it designed specifically for school SLPs because you're limited and not able to eliminate the tongue thrust, but there's still so much you can do. Okay. And then the flagship, if you will, the original STTP professional certification is for this program. I am adding in the STTP modified. So if you have these kids with articulation on your caseload that you're not treating for tongue thrust. I know you do. And so, because I did. So I am including the articulation program and the early intervention education program. So if you are doing the clinical certification, you get the certification course, the modified course, the early intervention program, and a referral PDF that you can, I laminate, and I call it a referral slick. So it has my clinic information on one side, and it has the features and characteristics that we talked about today that you can then give to your referral sources and even your families to be able to educate them as to what it is you're looking at. And it's nicely done, and you can individualize it to your own clinical practice. Okay, so the one I'll send you is obviously for the STTP Training Center, and then you can modify it for your own marketing purposes. But so again, it's the professional certification course, the modified course, the early intervention course, and the marketing slick, all bundled in to the STTP professional certification package. Okay. And then the second one that I'm offering for this presentation today is the school certification course and the early intervention course for the education. If you've got some littles, like I have some preschoolers, they're so much fun. And you can really do some education with their paras or their preschool teachers or their daycare providers, wherever you have interaction. Okay. And then for that group, the little friend fun takeaway freebie that I'm throwing in is an HEP, the home exercise program sheets. And I did up some summer program for my preschoolers and for my my secondary schools. So the elementary, this year I had lots of high schoolers and middle school and junior high. That was primarily my caseload with some preschool thrown in for fun. And so I did some home exercise sheets for the parents, and it was so, I mean, people were just crazy over them. And so I'm going to throw those in with that school certification bundle. So you have the clinical STTP professional certification bundle, and you have the STTP modified SLP, school SLP certification bundle. So both of those are just full of information. And the cool thing is that I'm doing it right now. It's only available while I'm doing this course promotion. And the reason is because I want you to get set to go back to school. Okay, this is the best time. This is always when I have the most people who are saying, I want to get my child's tongue thrust taken care of before they go back to school. So in the clinic, it's a good time for referrals and just wanting to have it cleaned up before school starts. And you still have time to do that. That's what's crazy. And then for the school clinicians, you're going to come into your caseload in the fall with a whole new set of goggles, I call them, with your new goggles to be able to look at your caseload and attack it in a whole different light. And the feedback I've gotten as I've shared this, we had a pilot group that did it in 2021. And we have another group that trained in 2022. And I will tell you, when we did our all ages workshop, which kind of had this entire bundle, they did the STTP. That's kind of what gave me the idea for it. It was these clinicians who worked in the clinic and contracted in the schools. So they had all these ages. And their favorite part of the training was the early intervention program because it was so unique to what we do. So it's a lot of fun. And that's why I thought, you know what, I'm just going to throw it in there because you may not even recognize that you have value in that, but you'll find value in that. Like I said, whether it's your kids, whether it's your kids that you come in contact with, your nieces, your nephews, or your grandkids, it's fun. It's super, super fun to do. So I'm going to throw that whole bundle in there. If you are doing all three, the price for all three of these plus the slick is $9.99. And that will be available probably for about a week because I'll allow those who couldn't make it to the presentation today to watch the video replay. And then we'll give a few days to be able to get that going. And just to be honest with you, like I said, I've changed my technology and my email servers and providers and all these things. So I need to make sure I can get it to you and that you can access it. So I'm going to give you about a week. Let's make this run until the 1st of August. Okay. So you have until like that price will go away. Now, obviously you're going to be running short on time to get done before school starts. So you're going to want to start sooner rather than later, but I will leave that price available for the bundle, which is a huge savings because just the certification course online by itself is, I think it's $850. And then the STTP modified by itself is $199. And then the STTP. So they all, they're the EIP. So they all, if you were to do them individually, you're looking probably close to 1,300. And then of course the SLIC and the home exercise programs, you know, those are added values. So for the, if you're choosing if you're a school SLP and you just want to do the modified with the early intervention thrown in and the home exercise sheets, that's going to be $199. So again, a huge value. The difference there is really the clinical SLP is truly eliminating tongue thrust. You can run a complete niche caseload and really develop that. I am here for you. I will help you do that if you have a desire to do that. The STTP modified, you're really not addressing the tongue thrust, you're addressing the effects of it. So it's really, that's the difference. The training is much more in depth on eliminating the tongue thrust and dealing with the swallow for the professional certification. So it's just much more time than the STTP modified. And so what you can do with it and the time invested and the level of expertise, if you will, that you come out of the STTP2 certification with is much higher. And that is why you're investing your time, you're investing your money to develop that skill set. Okay, still way less than if you go down the OMD route. Way less. And I will also tell you that every single thing we do is very, very applicable. Just like I hope today you're able to now look at some kids or think about somebody on your caseload and go, okay. And that you actually got that value today. I hope that you left with tangible takeaways, because that's what the training center is all about. Yeah, I think that's everything. The modified package or the professional package. And that is not to say that our school SLPs are not professional. You absolutely are. But that's how it evolved. Okay. So it's not an indictment on skills at all. It's just recognizing that in the schools, we're allowed to do things a little bit differently, required to do things a little bit differently. Okay. So which protocol is right for you? Which bundle do you want to take advantage of? Like I said, I will send out an email to you. If you do not, if for some reason you have seen this video and you haven't given me your email, so you're not signed up, I need you to email me, STTP training center at gmail.com. Okay. That's the shorter one. It's easier to remember, STTP training center at gmail.com. And if you are, make sure that STTP training center at gmail.com and Callie at stonetonguethrustprotocol.com. That's really long. That's why I don't give you that one. But just make sure those are both in your primary email address, because if not, the email server, because I send from a server, it will often end up in promotions, junk, spam, follow-up, whatever folder. So make sure that you've put that address into your primary so that I show up in your box and you can take advantage of this, right? Because this is an absolute value. It is so, you'll never practice the same again. And I'm super excited to give that to you. So thanks for coming today. We went a little bit over because I'm into the treatment. Let me go back to stop share. There we go. So yeah, I need to get that email stuff all set up and I will get that sent out to you. Choose your certification course package or your STTPM certification course package and make sure you get going on that. It will come down in about a week. All right. Thanks for taking the time to join me for this training, and I will see you in one of the certification courses at the training center. Bye-bye.